repetitive non-epileptiform contraction of muscle during sleep. Patient is unaware of the incident. Periodic limb movement disorders are 0.5 to 5 seconds in duration. They occur every 20 to 40 seconds during NREM sleep. It is often accompanied by K complex or brief arousal signal. It is associated with folate deficiency, renal disease, anemia, and use of antidepressants. Treatment of this is benzodiazepines like clonazepam, opiates. Narcolepsy is a chronic sleep disorder which is characterized by overwhelming daytime drowsiness and sudden attacks of sleep. People with narcolepsy often find it difficult to stay awake for long periods of time, regardless of the circumstance. It is triggered by emotions, any emotion like sudden laughter, anger, anything. Symptoms include cataplexy. Cataplexy means, as you see in this figure, there will be complete loss of muscle tone when patient falls asleep, excessive sleepiness, sleep paralysis, hallucinations around sleep, disrupted nighttime sleep. This is complete strong emotional trigger leading to partial cataplexy. There you can see weakness in the face and neck, then weakness in the limbs and trunk, and then complete cataplexy. There are two types in narcolepsy, type 1 and type 2. In type 1, demonstration of CSF hypocretin 1 deficiency, a mean latency of less than 8 minutes with evidence of sleep onset, rapid eye movement periods less than 15 minutes. Simply, narcolepsy type 1 is with cataplexy, type 2 is without cataplexy. Multiple sleep latency test. It is the standard investigation for assessing daytime sleepiness objectively. After monitoring amount and quality of previous night's sleep, patient is given 4 or 5 nap opportunities at 2-hourly intervals, and subject rests in quiet darkened room, and the latency to sleep is determined. Average latency from lying down to stage 1 sleep is noted. Management. Treatment goals is to reduce the daytime sleepiness and to manage the symptoms of cataplexy, sleep paralysis, sleep-related hallucinations when present. Drugs will be monoaminergic stimulants like methylphenidate, dextroamphetamine, mixed amphetamine salts, modafinil or modafinil, atomoxetine, bupropion, anti-cataplectic drugs like venlafaxine, desmethylvenlafaxine, duloxetine, fluoxetine, or tricyclic antidepressants. Psychosocial treatments, scheduling regular brief naps. These are also called power naps. Obstructive sleep apnea, also famously called OSA. Firstly, few definitions: apnea, hypopnea, and RERA. Apnea means complete cessation of airflow for at least 10 seconds. Hypopnea is decrease in the airflow of more than 30% for more than 10 seconds associated with oxygen desaturation of 3% or more from baseline. RERA, respiratory effort related arousal. RERA means increase in the respiratory effort for 10 seconds or longer, leading to arousal from sleep, but does not fulfill the criteria for apnea or hypopnea. So there are some indices of sleep disordered breathing. AHI, it is commonly used in clinical practice. AHI is defined as the average number of episodes of apnea and hypopnea per hour. Respiratory disturbance index, it is defined as the average number of respiratory disturbances like obstructive apneas, hypopneas, and RERAs per hour. What are the etiological factors of OSA? Firstly, anatomical factors: enlarged tonsils, particularly in children; volume of the tongue. Volume of the tongue will be bigger during in hypothyroidism, acromegaly, etc. Soft tissues. In obesity, soft tissues are more filled up with fat, leading to the uh, decrease in the airways, lateral pharyngeal walls, length of soft palate, abnormal positioning of the maxilla and mandible. These are all the anatomical factors causing OSCA. Neuromuscular factors. There is decreased neuromuscular activity in the upper airway, including reflex activity. Reduced ventilatory motor output to upper airway muscles. Structural factors. Innate anatomic variations like facial elongation, posterior facial compression, retrognathia, micrognathia, mandibular hypoplasia, inferior displacement of hyoid, Malampati grade 4, adenotonsillar hypertrophy, Peary-Robin syndrome, high arched palate, nasal obstruction, retropalatal obstruction, retroglossal obstruction. The non-structural factors like obesity. Most commonly, obesity leads to OSA, central fat distribution, male sex, mostly it is seen in males with a ratio of 2:1, postmenopausal state, alcohol and smoking use, sedative use, habitual snoring with daytime somnolence, supine sleep position, REM sleep, hypothyroidism causing macroglossia, increase of tissue mass, myopathy, neurologic syndromes, post-polio syndrome, muscular dystrophies, acromegaly. Mechanism of OSA. Here you see normal airway in this photo, whereas here there will be OSA. There is uh, this soft palate is obstructing the airways, so there will during that narrow passage the soft palate will be moving like this, causing snoring. Neck muscles relax as neuromuscular output declines with sleep onset. As pharyngeal airway has no bone or cartilage, there will be transient episodes of pharyngeal collapse, and episodes of collapse are terminated when ventilator reflexes are activated and they cause arousal. When to suspect OSA? Firstly, take history. Nocturnal symptoms will be snoring, witnessed apneas by the partners, gasping and choking, nocturia, insomnia, restless sleep. Daytime symptoms will be excessive daytime sleepiness, morning headache, daytime fatigue and tiredness, cognitive deficits, memory and intellectual impairment, morning confusion, gastroesophageal reflux. Excessive daytime sleepiness usually begins during quiet activities like reading, watching TV. As the severity worsens, patients begin to feel sleepy during activities that generally require alertness, like in school, driving, work related, etc. Reduces quality of life, impairs daytime performance, and causes neurocognitive deficits. It is assessed during Epworth Sleepiness Scale. This is the famous Epworth Sleepiness Scale. You will be given 0 with no chance, 1 slight chance, 2 moderate chance, and 3 high chance. There are parameters are there, 7 8 parameters are there, like sitting and reading, watching TV, sitting inactive in a public place, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol, as a passenger in car for an hour without break, in a car while stopped for a few minutes in traffic. So you pause the video and you can check this Epworth sleepiness scale, and you can give the score for the patient. Epworth Sleepiness Scale score of 12 is associated with greater propensity to fall asleep on multiple sleep latency tests. This Epworth Sleepiness Scale is useful for evaluating responses to treatment. So with treatment, this score should decrease. Likewise, Stop Bank questionnaire. Firstly, physical examination. Measure BMI. BMI greater than 30 has more chances of having OSA. Large neck circumference, more than 17 inches in males, 15 inches in females. Increase Malampati score, narrowing of the lateral airway walls, enlarged tonsils, retrognathia or micrognathia, high arched hard palate. Grading: mild, moderate, severe. Mild will be 5 to 15, 5 to 15 events per hour. Moderate will be 15 to 30 events per hour. Severe will be more than 30 events per hour. OSA diagnostic criteria: clinical symptoms of nocturnal breathing disturbances or daytime sleepiness plus AHI of more than 5 per hour during sleep study, or absence of symptoms with AHI more than 15 episodes per hour. Systemic effects of OSA: angina, So during angina, coronary artery disease, type 2 diabetes, all hypertension, atrial fibrillation, congestive heart failure, drug-resistant hypertension. Firstly, rule out OSA. Rule out any sleep apnea related disorders. In all these drug-resistant hypertension, drug-resistant resistant uncontrolled diabetes, all hypertensive cases, AF